Hello, folks. Welcome back to the next episode of the Dental Implant Podcast. And I am very happy to have Dr. Sami Numbisi back for his second episode with us. I'd love to give you a little bit more of a rundown with regards to Sami's background, to say that he is a pioneer of ceramic implantology is a little bit of an understatement, and I don't want to do him any disservice and forget something. So, Sami, would you mind just giving us a little bit of more information about your background so people know who they are talking to?
Well, thanks for inviting me. Thanks for having me back on your podcast. It's an honor. It's always a pleasure. So my background is I started dental school in Washington, D.C. at Howard University in 1993, 1994. And upon graduation in 1998, I went to Loma Linda University, where I did a residency in implant dentistry. So that was a 3-year program, which I completed with a master's and a certificate in implant dentistry. So like everybody else, like the majority of implantologists, I was trained traditionally on titanium implants. I got my thesis in sinus grafting, and as a resident, by the time I was done, I placed quite a few implants. And I practiced conventional, traditional implantology for about 10, 11 years. And I had a practice. I purchased a practice in the area here. And the practice I purchased had a lot of patients who were very conscious about their health, about metal-free, about, natural things and all that kind of mindset. And believe it or not, I was introduced to ceramic implants by a patient. It's a patient who said, hey, I just spent a lot of money removing metals out of my mouth and cleaning it up, and now you want to put new ones. And I looked at the guy, I said, well, how else do I do it? The only way I know is with ceramics is that they're not very successful implants. That's what I was taught. That's what was the common thinking at the time. So I did he said, well, I saw one online. Back in the day, you had to print something. You could not there were not a lot of smartphones. So he found the information and gave it to me, and it was pretty compelling. And I started looking into it, and I never looked back. So I've been doing ceramic implants now for almost 15 years, published a lot of articles on the topic.
Yeah, I read them. I know.
Yes, I have written a few book chapters. I have a couple of books that are coming up, one at the end of this year and one in the beginning of, probably the first or second quarter of 2027. So there's great things coming up because there was a need to organize the information.
Yes.
The information is available, the science is there, but it's all over the place. And most clinicians don't have time to go and find it and dig it and bring it in. So those two books are really going to bring the scientific and clinical information and an explanation of the clinical decisions backed with scientific evidence. So that's the things coming up. And as I went along in my journey, Pav, there was also a need of clinical, practical education, and there was also a need to have a platform where doctors who adopted ceramic implants felt comfortable and safe to talk about ceramic implants. And that's how I founded the International Academy of Ceramic Implantology in 2011. And we started having, and yes.
I was just going to say, remind me about that later, because my understanding is you have a congress later on in the year. Right. So I want to pick your brains about that as well. Yeah. So yeah.
I was going to mention that, but yeah. So we created, but we can leave that so that you can bring it up. Yeah. So I founded the academy, and that was an environment where doctors that were either already placing ceramic implants or who were willing to learn or who wanted to have a space where they could share experiences could come and get together once a year or online or whatever and do that. So in a nutshell, I went from being an adopter to being a user, still a big user of ceramic implants, and an educator of ceramic implants.
So I'm a little bit behind on that curve, but I feel like I'm following the same trajectory as well.
I see you coming.
Yeah. And a big influence of that was yourself, Sami. And when I started to I'll tell you now is some of the listeners are going to be going, oh, for God's sake, ceramic implants, they don't work. I know that there will be. But when you actually look at the evidence, yes, ceramic implantology, when it first took off, it wasn't as successful as titanium implants. However, the modern day ceramic implants, they work exceptionally well. I feel the other thing that I personally feel I need to separate out as well is I don't consider myself a biological dentist. I know there are some dentists out there who do consider them biological dentists, and they will refuse to place titanium implants. I still place plenty of titanium implants. I just give my patient options where it's feasible. From my perspective, there are pros and cons to titanium, and there's pros and cons to zirconia implants as well. Absolutely. And I feel that zirconia gets a bad rap because people still perceive it to be the products that we had like late 80s, early 90s. They're not looking at the newest data, and they may be speaking to some colleagues where they are deep and heavy into the biological aspects. And we're not here to judge. We're here to say that, look, there are options for patients, and that's all that it is. And I would express to yourself as well, Sami, is my ceramic implant journey started because of the exact same reason as yours. I had a patient where she's like, I'm allergic to just about every bloody metal that's available. I don't want metal in my mouth, but I've only got 3 teeth, and I cannot I cannot wear dentures. She goes, my gag reflex is too strong. So actually, my first ceramic implant was a full mouth rehab. So wow. I jumped in feet first on that one. But you know what? Is when I saw the results of it, I was like, actually, you know what? This is actually quite impressive. Yeah. And then I started to do more of the research. Then I started to see your name come up. And then we've been connected on certain WhatsApp groups for quite a number of years now. Yeah. And I think last time you put me in contact with a colleague in Europe as well, who does a lot of zirconia implants, Andrea Borgonovo, yes. Max consultant. Because I remember you saying, oh, I'm going to put you in contact with a friend of mine. He's in Milan. His name's Andrea. He's a Max consultant. Yeah. I said, is it Andrea Borgonovo by any chance? I said, yeah. I said, I've got his WhatsApp number. I'll message him right now.
And he's published a lot of good literature too on the topic. Yeah.
He's published a lot. And you know what? The data clearly states that, it works exceptionally well. Mm-hmm. I feel that what I want to ask from yourself now, because the last time that we spoke about this, Sami, was we were almost going into the history of ceramic implantology. Okay. What about the future? Tell us where things are starting to head now. So one of the things that I saw on the Congress is we're really starting to collate data a lot better together now, and we're starting to have a better idea with regards to the boundaries that we can push. So tell me a little bit about, we've kind of like done the history. Where do you feel everything is heading in the future?
Well, that's a very good point. What's historically, and that, to just briefly go back into what you were mentioning a few minutes ago, is that, ceramic implants had a bad rap precisely because of how they were made originally. Okay, the original ceramic implants were all alumina or all zirconia. Well, zirconia we know doesn't tolerate humidity. Alumina we know is very brittle. So that those two original ways of trying to make ceramic implants were just not viable, because they either degraded or they fractured. Okay, so fast forward, like in the early 90s, mid 90s, or late 90s actually, we started to see what we call zirconia composites. So now we started to have zirconia put together with alumina, and then put also with yttrium. And all those three components are supposed to work together to give the ceramic properties very similar to a natural tooth, or at least that similar to a titanium. Okay. So what are we looking for? We're looking for tensile strength. We're looking for the ability to bend and rebound and not crack, not fracture, avoid cracks. So we got to the composites. The composite took us 10 steps ahead. But once we got to the composites, that was not enough. We decided, well, we probably need to find a way to improve those composites where their physical properties are just better, where their stability in the wet environment of the mouth is a lot better. And what I mean by stability is this, is that just like metals that corrode in certain environments, ceramics, zirconia composites can break down over time in a wet environment or under stress. So what they started doing, it started evolving into hot isostatic pressed, hipped, like they say, hipped zirconia. Then we went into zirconia toughened alumina toughened zirconia. So now, just like alloys, the composites started changing. Some people did a little more percentage of alumina, a little more percentage of zirconia. And then we became even more demanding on ourselves. We decided, well, why can't zirconia be aesthetic? So we started increasing the yttria content, which gives it a better light transmission. So now today you find that you have some places, some labs that can offer you what they call aesthetic zirconia. So moving now forward, looking ahead, because all what I've said we already have. Looking ahead now is we're starting to talk about bendable ceramics. So now we're seeing that the technology and the manufacturing process and the understanding of the material is so much better that now we're able to make some manipulations to the composite, to the chemistry and whatnot, and make them more flexible. So they they can bend more, go farther in the stress without fracture, without catastrophic failure. So that's where we are. And just recently, I was very pretty pleased, I should say, to see that there was an implant system now that has MUAs on ceramic implants. The
Wow.
Neodent Z. Yeah, the Neodent Z is not available in North America yet. I don't know about Europe, but it is definitely already being tested and used in Brazil. And now they're coming with these MUAs on ceramic implants. They were one of the first ones to have a bone level ceramic implant. So future-wise, we're leveling the playing field now. So meaning we have bone level, we have angular abutments, we have MUAs in the pipeline. So a lot of what, and I'm sure your first full arch case, just like my first full arch case on ceramic implants, was a lot of work because you just didn't have all these angular abutments, you didn't have all these correction tools. But that's
Everything
now,
had to be everything had to be.
yes.
Unfortunately, this patient had plenty of bone. So in that context,
In that context, yeah. And the majority of full arch ceramic implants today are still somewhat limited to patients that are ideal with a lot of bone and whatnot, maybe immediate placement and things like that. But once you start needing angulations or corrections, that's a little bit where it's lagging in terms of full arch restorations. So my first full arch was all with one-piece implants. Can you imagine? I mean, they had to be dead on. The case had to be ideal. But now you see, looking now, the future is here. I think those MUAs are going to be on European and US markets probably by the end of next year. And you'll be able to place ceramic implants and restore them similarly to what you do with titanium implants. So the future is really good. It's really bright. I think this. I got in 15 years ago, and we had a lag time of about 10 years. But in the last 5 years, things have been moving really, really fast, material-wise, prosthetic component-wise, etc. Yeah.
So one of my bugbears with regards to not just ceramic implantology but titanium implants as well is suboptimal implant placement. Weird angulation, just because people refuse to go guided.
Yeah.
And I've seen the research on biomechanics, and if people understood it, I think everybody would be frightened into going guided for just about everything, because it's very easy to increase the torque through the implant abutment interface by 200%, 400%, 500%. And then the implant neck fractures and people are like, oh, well, that implant system's useless. It's like, yeah, but look at the angulation of your implant. Even if it's not angulated correctly, maybe it may be perpendicular to the occlusal plane, but it's offset. Do you know what impacts that has? So I tell my delegates, particularly when they're doing my diploma, is I say to them that, if I see your lab prescription and all it says is screw retained crown, I said, you're in trouble. I said, because you won't pass on that. Now, the issue that I have for that is I also feel that, I use Bredent White Sky. And with it being a one-piece implant, Whilst you can prepare the abutment, I don't like to prepare the abutment.
Mm-hmm.
I much rather prefer to go guided and have it prosthetically driven as it should be, so that the crown goes in at the correct angulation. All of the forces going through the implant are vertical, so they're compressive.
Correct.
Because nothing likes shear forces. If people looked at the data, bone doesn't like shear forces.
Yeah.
So this is one of the downsides that I say to zirconia is I feel that you have to plan and execute at an even higher standard than what we have to do with titanium implants. Because we were saying pros and cons, right? Yeah. I feel that zirconia is less forgiving, but that's not to say it can't work. It just means to say you have to plan and execute it properly.
I always tell my students, I say, you got to up your game.
Yes.
You can't just go and just do what you used to, because titanium is very forgiving.
Yes.
It's a very, very forgiving material, even in terms of biomechanics, as you just suggested, but also in terms of the environment in which you place those implants. You place titanium implants in a diabetic guy or a smoker or a not so great hygiene guy, they'll work. You try to do the same thing with ceramic. Now, things start to change a little bit. And I always say, and I again, even myself, I don't do that all the time. But a lot of times you also want to know the health status of your patient.
Yes.
Because if you and I were to collapse now and be taken to the hospital, the first thing they're going to do is do some blood work. They're going to try to find out, okay, what made him collapse? Okay, now that we know what the problem is he able, now that we're looking to see what the problem is, the first thing we do, we draw his blood. We find out, okay, what's the white blood cell count, whatever. Before we even go and do anything. But we in dentistry and oral surgery, we just do a lot of procedures and they work.
Yes.
And a lot of times we don't know why they work, but they work. And now when you go into the ceramic implant world, because they don't have any coatings, they don't have any osteoinductive surface treatment. Now the host contribution to the osseointegration of that implant is a lot greater. They have to be able to heal from that surgery. They have to be healthy. And there's a lot of other factors that have to be evaluated for it to be successful. So that's why I say up your game, not only in terms of placement, but in terms of treatment planning, in terms of biology, physiology of the patient. Yeah.
I also feel that, as you were saying, because a lot of the reading that I do is actually orthopedic journals. The amount of data that I've gone from orthopedic journals is crazy. We find something new in implantology and we think that we're cutting edge. We go to the orthopedic surgeons. We tell them, have you ever thought about this? And we've been doing that for 25 years. Catch up.
Correct. Yeah.
And I can't imagine an orthopedic surgeon doing any significant surgery without full blood works. If they're replacing a hip or knee, they'll want to know vitamin D status. They'll want to know cholesterol levels. Yes. They'll want a full blood count, because it's the body that heals. It's not the implant that heals. It's the body that heals. Mm-hmm. So, okay, we touched look, there's some exciting things coming on with ceramic implantology at the moment. One of the things that's really becoming it's almost like a buzzword over the last few years, Sami. It's osteoimmunology. Okay, it's the link between the immune system and bone healing, effectively. Now, I saw that you have got a gentleman coming to the Congress who I look up to because he thinks very biologically like myself. In terms of biomechanics, he thinks the same of myself. You probably know that I'm talking about Alberto Mizzelli.
Yeah, okay. Alberto, yes.
And he's going to be going on, I know he's going to be talking about osteoimmunology. So Absolutely. Can you just touch a little bit on that as well for me, please?
Okay. No, really, it's again, you're right. This is one of these aspects of implant dentistry. Again, upping your game, all right? So now it's not about the best implant, the best surface, the best company, blah, blah. No. The patient has to heal. And that's where osteoimmunology comes in. I'm not an expert in it, but I understand it well enough that I've seen it had a good impact on my practice. Now, what's osteoimmunology? Basically, its name defines it. What's the immune component of bone healing, not even only osseointegration alone. So now, if you look at the literature and you look at the facts that we know vitamin D contributes to bone healing. We know vitamin D contributes to health, the performance of the immune system. So now you connect vitamin D, you connect cholesterol, you connect osteoblasts, you connect osteoblastogenesis, and all these things, they all come together. It's physiology. We learned all this in dental school. It's just that, as we practice and we tend to become more mechanical than we're thinking about the physiological part of things. But osteoimmunology basically says, if your patient's immune system is not optimal, you're most likely not to have a good response or an optimal osseointegration of any device that you're going to implant in a patient. Because it's interesting what they show is that, if the immune system is not very good, the osteoclastic activity is higher. So if you have the osteoclasts that are busy and that are overwhelming everything else, you lose bone and you lose the implant, or the bone doesn't turn over fast enough for the implant to be osseointegrated. So it's an aspect that Alberto is going to be speaking to us about. And it's a very interesting component of implant dentistry. Again, it goes back to the blood work, the assessing the patient. Can they heal from this procedure? Do they have the nutrients? Do they have is the immune system ready? What's the white blood cell count? Is it too high? Is it going to affect, all these things? So yeah, it's exciting.
So I've already done a podcast with a Max Frax friend of mine, Stavros Eleftheriou,
yes.
And we spoke about this. We spoke about osteoimmunology and the body's ability to heal. Mm-hmm. And again, we don't need to worry so much about the successes that we have. Although people forget that actually, the rate of peri-implantitis after 5 years is almost 50%. Yep. Okay, people look at success at, I've just fit the crown, look how good my bone levels are. It's like, let's see what they look like in 10 years' time. Yeah. Okay. Another mentor of mine, Howie Gluckman, he's passionate about delivering only the best for the patients. His treatment philosophy has been influential on mine. Mm-hmm. And again, one of the things that we talk about when we talk about osteoimmunology is the concept may be complicated and we don't know everything about it. Okay. The medics don't know everything about it, but sometimes the application, all it means is you are just changing your philosophy and your approach. There's no additional cost. There's no additional treatment time or anything like that. You just think about things differently. Okay. So we're not advocating all of a sudden you have to read a new textbook and it's going to add another hour onto your treatment plan. Yeah. Sometimes it's as simple as, you just need to think about things differently. Mm-hmm. And again, another one of my bugbears, and I have this argument a lot with people, I don't like backing down from it, is they turn around and say, well, my patients appear to be healing fine. Yeah, to your eyes. But what? Biology works on a macroscopic level. Have you zoomed in to see what's actually happening on a microscopic level around your implants? Mm-hmm. I just feel that, let me think about the politically correct way to say this. A filling's a filling at the end of the day. Okay, doing an occlusal MOD. Implants are a lot more invasive for patients. They're a lot more serious for patients. Mm-hmm. And I feel that we should be executing to the highest standards of what we possibly can. And in order to do that, we have to continue learning and we have to keep pushing the boundaries of what we do. Mm-hmm. And this is why I've been looking at osteoimmunology recently. And again, it's only really come to highlight for us as implant surgeons over the last 4 or 5 years. Okay. For medics, they've known about it for 20, 25 years. They've already started implementing all of this stuff. So this is why I always say, if you want to look at the most up-to-date research, start looking in the orthopedic journals. These guys are light years ahead of us.
Yes. Especially as an implantologist, that's where you want to look for information, because they do pretty much what we do, but they do it at a bigger scale with hips and knees, whatnot. But it's the same concept.
Yeah. I respect the fact that we are working in a different area of the body. Generally, the blood supply that we have in the mouth is far better than what orthopedic surgeons have to work with. But at the end of the day, the body's still healing, and that's what it comes down to. That's what it comes down to. Okay. So one of the other things that I saw about is that you're going to be discussing photobiomodulation, which surprisingly, again, is something that I've been looking at quite recently. A lot of historically it used to be called low-level laser therapy. Right. On a very simplistic level. A lot of people call it red light therapy. Yeah. A lot of people say that it doesn't work. It's a load of nonsense. And the answer to that is actually when you look at the data, it does actually work. Yeah. But again, we're relatively early-ish. Mm-hmm. in our understanding of it. So we know that it works, we know how it works, but what's difficult to ascertain at the moment is it's very much dose dependent. Yeah. So if you are trying to get a certain outcome from it, it's if you don't give enough, it doesn't. You may as well not have bothered. If you give too much, it gives a counter effect as well. So I'm happy to see that you're going to be going into photobiomodulation as well, but I've seen you using photobiomodulation on your patients.
Yes.
Every time I see it on your Instagram, I'm like, you know what, dude? I do the exact same thing.
Yeah.
Well, Sami, tell us a bit more about PBM.
PBM is, I have a little saying about PBM. I said, PBM, the minute the universe created the sun, PBM took life. It's all about red, near infrared, it's light.
Yes.
So light, if you look at every culture, just about every religion, they celebrate the sun. They celebrate light. African, East Asian, whatever, there's always something about the sun, right? So the light has always, the power of light is very, it's a lot more, it's very poorly understood. I mean, we know it's good for plants and whatever, photosynthesis and all these good things. But we don't realize at what point light has an effect on human beings. It has an effect on our mood. It affects even the types of hormones we have. Again, going back to vitamin D, which we call vitamin, but it's really a hormone. Yeah. The light impacts a lot how much of that hormone your body can make. Okay. So when you go into photobiomodulation, red light therapy, low-level laser therapy, there's two principles with that, which you actually alluded to, is the dose and the frequency. It's not like a pill, you take it and no, you have to apply it incrementally at a certain frequency over a certain amount of time for certain purposes. So, for example, you were mentioning my post with PBM on PRF, for example, using it. That's a different frequency that's used to put energy into the cells that are into that PRF. Increase the ATP and all that stuff, and potentiate the cells so that when you put them into the environment where you want them to work, they have the energy to perform. Okay, it's all about energy. So, how does it relate to dental implants? Well, again, when that light goes in, there's a cascade of physiological events that happen that facilitate the osteoblasts, the osteoblastogenesis, even to begin with, and that. When all these things come into play, that allows for better recovery. So it also influences inflammation. So you find that people that you put on the red light therapy tend, in a proper protocol and consistent way, they will have less swelling, they will have less pain. But it's not just doing the light as they leave out the office and then they're gone. They have to go home with some type of a light or have a light at home that they can apply under a certain regimen. There's different regimens depending on the manufacturer of the lights. But the goal of red light therapy is potentiating the cells, both for repair, but also to control inflammation for the most part. At least as far as implant dentistry is concerned. Yeah?
So I can hear Marco Esposito in my ear because obviously, Marco's very much into his, he's probably written and done more meta-analyses and run control trials.
I've read his work, yeah.
I think we have to be careful. There is a difference between clinically demonstrable evidence and like early stage evidence.
Yeah.
I feel that with PBM, we are kind of like in the early stage evidence because again, at the moment, we don't know what the exact dose is going to be. All of this needs researching, right? Mm-hmm. In order to figure out whether it actually works, we need, randomized control trials, split math studies, X, Y, Z, and then, blinding, double blinding, triple blinding, whatever it needs. And we're not at that stage yet. But on the flip side of that coin as well, last year I went over to see Prof. Testori in Lake Como.
Yeah, Tiziano.
He said as well, he said, listen, he said, Pav, he goes, sometimes we do things because we have a strong evidence base behind them. Because sometimes we do things because it just makes sense. And he was, it's very simple things like when he's doing a sinus graft, before he places a graft, he'll change his gloves. Simple, because we've been working the mouth, we've been touching mucosa, this and that. So sometimes we have to. I feel there's two aspects to it. There's a strong evidence base and there's a philosophical base to it.
That's right.
And what we have to be careful of is we do need to be careful with that philosophical base, and in more than anything else, make sure that we're not doing harm to these patients. Okay, but certainly with PVM, there is some evidence behind it. Worst case scenario, we're wasting our time. But from the cases that I've been seeing and that I've been doing, the patients like it. It feels nice for them. They've turned around and said, I didn't really have that much discomfort, didn't really have that much pain.
I would agree 100%. Like, for example, for me on a personal level, I'm a runner. I run, I bike. And my recovery, I have a red light at home. And I got the red light about 6 months ago. And my recovery, like the lactic acid, the strain or the muscle pain after, it goes away faster or doesn't occur. Because again, some people might even say, oh, when do you do this now? Well, you do it before you go for the run and you do it after.
Yeah.
Because if you only do it after, it doesn't work as well. But you're right. We're now in a crossroad between our philosophical and scientific evidence. And I think with red light, we're quickly merging it.
Yes.
Those two components. And I think we're rapidly going towards a situation where we're going to have more and more scientifically backed clinical evidence of red light therapy.
Yes.
Actually, Dr. Raoul Desai, who's going to be speaking about that at the next event meeting, he's also a user of red light therapy for himself as an athlete and as a surgeon himself. So I've seen amazing things happen. If I may use the word, potentiating my PRF with red light, supporting my patients pre and post surgery with red light, myself personally with red light, my sons who are athletes with red light. But just the idea of shining a light somewhere and saying that light is gonna reduce swelling or decrease the intensity of pain is hard for a lot of people to believe, but it works. We see that in the clinic, and it's not new. It's not new. That's what people don't understand.
No, it's
red
not.
light therapy goes back to the 60s, 50s.
Yes.
We knew already that.
Yeah.
But I say all the time, red light therapy, photobiomodulation came around when the sun was created.
Yes.
We never created the sun.
Yeah. I like that.
Yeah.
Okay. So, Sami, we've kind of like bounced backwards and forwards quite a little bit. I'm really excited that there's these new things coming. So, just before we start wrapping up, can you tell us a little bit more about the Congress? Is it in? You said Miami?
No, it's in Chantilly, Virginia.
Okay.
Which is a suburb of Washington, D.C. It's about...
All right, okay. Yeah.
On a good day, because D.C. can have traffic, but on a good day, it's about 25-minute drive from D.C. So
okay.
This event is an event that we've had yearly, except last year, for the last 15 years. And this is going to be 15th year anniversary of the IOCI.
Congratulations.
Yes. And it's also a very unique, special year because, again, there's a lot of things coming up. We just talked about it: the red light therapy, the vibration therapy, the all these things that are coming, osteoimmunology, all these philosophical, pretty much scientific things that are now coming. So what we're doing this year is it's going to be implantology, but it's going to be implantology, what I like to call implantology 3.0. Okay.
Yeah.
3.0 because not only because it's ceramic, but also because of all these other attached or these other techniques, technologies, philosophies, like you said very well, that are coming into play and that are now increasingly proving that Whether you do titanium or ceramic, red light would always do good. Osteoimmunology is always a factor. Low intensity vibration is always a factor. All these things are going to always make your implant practice successful, your implant results good. So this Congress is really to not only bring experts in ceramic implants, but a little bit of the biological side of implantology. And so it's going to be 3 days, 2.5 days. We're going to have the first day is going to be workshops on some of these modalities and some of aspects of ceramic implants, even some business, because again, if you're doing ceramic implants, it's another modality you bring to practice. It's a little bit like bringing Invisalign. So you have to find a way to be able to present that to patients. You have to find a way to let the world and your referrals and the patients out there know that it exists and that you provide it. So there's going to be a business aspect of things also in terms of bringing these modalities in your practice. And the main day is going to be the second day, where we're going to have podium speakers, where some of our mutual friends, Alberto and others, are going to be there speaking about various topics and osseointegration, placement of implants, prosthetics on ceramic implants. Because again, you were talking earlier about the forces and how they should be, the implants should be placed in a way where they're not shear forces all over the place. Well, we're going to have quite a bit of talk about that. And going to the third half day is going to be this covering all these aspects also. So it's going to be 2.5 days of intense knowledge, new information, just, again, implantology 3.0, meaning come and look at where we need to now go, where some of us already are. And that's where probably all aspiring implantologists or existing implantologists probably need to start looking toward. Is that, your success is not just the brand of the implant. It's not just those special coatings. It's not just, it's made in Switzerland versus made in, I don't know where. So, it's just, let's go back to the basics, the biology,
perfect,
physiology.
What's the website for anybody who wants to search more about the Congress?
You visit www.iaoci.com/events. The Congress is September 10 to the 12th, 2026, and it's in the DC. It's in the Washington DC area. It's in the Washington DC metropolitan area.
Yep. Amazing, Sami. Thank you so much for your time today. Again, it's really nice to hear that people who are separated quite far from me in terms of geography, they have they're doing similar things to myself and looking up the same things as well. So it just goes to show that, it's evidence almost kind of like emerges by itself given time if you continue to learn. So amazing. Thank you so much.
Well, geography is no barrier to synergy. How about that?
Absolutely.
Okay,
so,
thanks.
Thank you so much. So just before we wrap up, for those listening, please also visit the academyofimplantexcellence.com, which is my training platform. I have 3 modules available: Essentials, Advanced, and Mastery. I teach you everything from what is an implant to this is how you do a full arch, and absolutely everything in between. The best thing about it is all of the theory is delivered online. If you wanted to study for a diploma, we have the Academy of Implant Excellence diploma in comprehensive and full arch rehabilitation. And yes, I do teach you about ceramic implants as well, because I'm passionate about them as well. Okay, so Sami, I hope the Congress goes amazingly for you. I'm sorry I couldn't join you this time around. It conflicts, unfortunately, with me lecturing on zirconia implants elsewhere. So we'll be in different.
You have my support.
About it.
You have my support. For many years I was one of the few going out there and passing the word about ceramic implants, and it's just so refreshing and rewarding for me, because if you believe in it, it's probably because you saw some of my work, you saw some of Andrea's work.
Yes.
And you believed in it, you bought into it, you grew into it, and now you're passing the knowledge. So,
and now I'm seeing the results for myself.
Yeah.
Now I'm seeing the results. Amazing. Thank you so much.
All right.
Folks, thank you very much for listening in, and I wish you all the very best, and hopefully I'll have the next episode out for you soon.